Welcome to your next installation of monthly basic training, focusing this month on the recognition and management of obstetrical delivery complications. What could go wrong? Well, a lot could go wrong. On the left are what I like to call the baby problems. On the right are mommy problems. The first delivery complication we're going to review is breech presentation. The fetus can present in a frank breech, which is where the butt is the presenting part, a complete breech, which is when both feet are the presenting part, and a footling breech, where one foot is the presenting part.
For a frank breech delivery, which is a butt presentation, you will deliver until the axilla is in view. And in that time, you're going to deliver both legs. Once you deliver to the axilla, you have access to the cord, and you'll pull out a 4 to 6 inch loop of cord. Deliver the arms. The head will rotate to anterior-posterior positioning. And voila. Place baby on mom's chest.
A true cord prolapse is a surgical emergency. Priorities are rapid transport to a hospital that has obstetrical capabilities and restoring or maintaining perfusion to the placenta. This is done by first placing the mother in either a knee-chest position, which is not ideal for transport, or a left lateral Trendelenburg with hips elevated on blankets, using a gloved hand, a regular glove with a sterile glove from the OB kit on top. Insert one hand in the vagina, exerting pressure on the presenting part, back into the vagina and off of the cord. You should be able to palpate a pulse anywhere on the cord if you're getting perfusion. Limb presentation also requires surgical intervention, but is not considered emergent as it poses no immediate life threat to the mother or baby. This is different from a footling breech in that the limb has already protruded through the vagina. Lower extremity limb presentation is generally the outcome of a footling breech.
Okay. You may also have a presentation of a footling breech. The procedure is the same. You will deliver to the axilla. Extract a 4 to 6 inch loop of cord. Deliver the arms as the head rotates. Sometimes you're unable to deliver the head due to the cephalic diameter in comparison to the pelvic outlet, and you need to create an airway. If that is necessary, you will place 2 fingers in the vagina and press down on the tissues to create a space for the baby to take a breath now that its lungs are exposed and it's able to expand lungs with a breath. Provide an airway with your fingers.
With multiples, sometimes it's simply just doing 2 consecutive deliveries. However, multiples come with increased risk for other complications such as malpresentation, breech, transverse lie, as seen in the graphic, prolapse cord. So with multiples, it's a mixed bag. Pun intended. Meconium-stained amniotic fluid. It happens a lot. Babies poop. It can't be prevented from happening. The goal is to prevent any meconium being inhaled. In a delivery, if you encounter meconium-stained amniotic fluid, go against your instincts to stimulate a flaccid baby. Before that baby takes its first breath, suction the mouth, then nose using a bulb syringe. A useful but tricky time to perform this suctioning is while the head is the only part delivered and still on the perineum. While the trunk is still in the birth canal, that baby can't take a breath. The lungs are restricted. If you can quickly remove any meconium-stained amniotic fluid from the mouth and then nose prior to delivering the remainder of the body, that's a pretty sure bet that baby won't aspirate meconium. Remember, if the baby took a breath before you had a chance to suction, just monitor and transport. ALS providers, you know the drill. If that baby delivers and has not taken the first breath, do not stimulate. Perform direct laryngoscopy using an ET tube, a meconium aspirator, and suction to remove any amniotic fluid that may have gotten below the vocal cords. Now we'll cover the mommy problems. Postpartum hemorrhage is defined as a blood loss greater than 500 cc's for a vaginal delivery. The indication to a field provider will be a patient continuing to bleed heavily after the delivery of a placenta. Once the placenta has delivered, if you have not already, encourage the mother to nurse her newly born. This stimulates the release of oxytocin and will help the uterus to contract, clamping off those exposed vessels where the placenta was attached. Providing uterine massage can stimulate contracting of the uterus as well. Place one hand on the fundus, which is the top of the uterus, and use the other to massage upward. Preeclampsia is a risk that has been extended to up to 6 weeks postpartum. The signs and symptoms are the same: pressure elevated from baseline, visual disturbances, non-dependent edema, nausea, vomiting, epigastric or right upper quadrant pain, and headache with light sensitivity. There are many risk factors that may increase the likelihood of having to perform a neonatal resuscitation. These are risk factors that may occur during the delivery process. Antepartum risk factors impact fetal development, creating a circumstance where development or function is incongruent to gestational age. These are the steps of neonatal resuscitation in order of action. Thanks to Captain Cy Stottlemyre, there is a handy mnemonic to help you remember the essential components of neonatal resuscitation. We will go over each one individually. Stimulate. Dry, warm, stimulate. Don't forget to cut the cord. Drying a baby vigorously with a towel or blanket can also be considered stimulation. Discard wet linens and provide warmth. Evaluate. Spend no more than 30 seconds evaluating the heart rate, skin color, and respiratory effort. Don't forget to assign an APGAR score at 1 minute and 5 minutes post-delivery. Ventilate and oxygenate. In the event that the newly born has ineffective or no respiratory effort, ventilate for 30 seconds at a rate of 40 to 60 breaths per minute. If the respiratory effort is adequate, but the newly born still has cyanosis of the trunk, provide blow-by oxygen at a max of 5 liters per minute. Circulate. If after 30 seconds of positive pressure ventilation, the newly born still has a heart rate less than 60, continue ventilating for an additional 30 seconds and provide chest compressions using the 2-thumb technique. Intubate. At any point in time during the resuscitation process, an advanced airway can be established using an appropriately sized endotracheal tube. Cannulate. Obtain access to provide medications. Medicate. Epinephrine is used for circulatory issues, dextrose for hypoglycemia, and a fluid bolus for suspected volume loss. Lastly, evacuate. Transport to an appropriate destination capable of obstetrical care and neonatal care.